Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Rami Komrokji from the Moffitt Cancer Center in Tampa, Florida, Dr. María Díez Campelo from the School of Medicine at the University of Salamanca in Salamanca, Spain, and Dr. Amer Zeidan from the Yale Cancer Center, Yale University in New Haven, Connecticut. They will be answering questions posed during a live symposium on managing MDS that was held during the annual Hematology meeting in December 2022. This episode is part of a larger educational program titled An Expert Discussion on Myelodysplastic Syndromes, Current and Future Personalized Management Approaches. For more information on the experts, along with a link to the complete program including downloadable slide sets, an expert commentary, and an on-demand webcast covering the topics discussed in this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
The first question was, does the IPSS-M reflect impact of any treatment? Can these prognostic scores be dynamic? This is obviously a very good question. The original IPSS was in a cohort of patients that were not treated, and the revised IPSS. I think the IPSS-M included patients that were treated. This is a prognostic model. And in our cohort that we validated, around 2,500 patients, all those patients were treated, and we see clearly the discrimination. Nobody had really looked yet if it is dynamic. I think there are a couple of presentations at this ASH looking at prior to transplant impact of the IPSS-M. The question is, if we have a patient that historically was a lower risk and now we upstage him, is that patient going to benefit from transplant? And we'll have to try to see how we can answer the question. It makes sense if we are really accurately estimating somebody's survival of being 2 years or less, that probably the maximum gain of transplant is to go to transplant immediately. But that's not been done. The other question asked, is there a difference in outcome of patients with missense TP53 mutations versus nonsense mutations? Most of the P53 mutations that we see in MDS, to my knowledge, are missense mutations. There is no difference had been reported based on the type or the hotspot. At least I know from the study that we did with the APR246, we tried to look at that and we did not see any difference. Maybe Amer, I'll ask you this question. How will the reclassification of high blast MDS impact therapy choices now?
Yeah, this is a great question. The short answer, I guess the big view in my mind is that we should have one classification, and hopefully those two classifications are going to be confined. I think the main advantage potentially is that it could allow access for some medications that are currently only approved for AML, which we have struggled for in the past. For example, you have a patient with 18% blast, and you want to use Azaven, and sometimes the insurance would decline because it's a younger patient. You are trying to bridge to transplant. You are trying to reduce the blast count before, quickly and not give intensive chemo at the same time. That could allow it. However, the idea is that the blast count should never be a strict cutoff, like the 20%. And there should be some clinical judgment in terms of where do you separate MDS from AML. But I think in terms of clinical trial design, I think this is going to create a lot of problems, and we are still discussing this among us and how also the regulatory agencies are going to approach this issue. I think ultimately that clinical trials historically in the cooperative groups, for example, high-risk MDS often were included with AML trials, but this has not been done in industry trials because it's very difficult to get an approval when you have a mixed AML and MDS. So I think most likely the 20% is going to continue to be a cutoff in my opinion, because the WHO is still the one that I think most universally used.
Thank you. There was another question about the IPSS-M. Will it be the new standard for prognostic risk outside of clinical trials and academic centers? I think we are going to see several validations at this meeting, and with the data published, I think people are excited to use this model. Obviously, with any risk model, you always think of how generalizable are those models, and they can be used all over the globe. Like I think in USA and Europe, it's standard that every patient gets NGS sequencing. But like when we talk to our colleagues in South America or in Middle East, those tests are not available. The good thing about the IPSSM, it does allow to give you a range of the estimate of the prognosis if some of the variables are missing. So it still will give you some information. So I think we'll move into it. I think the question would be really, if we apply this model now and we upstage patients, are we going to make a difference in the outcome for those patients? Maria, I think this question for you, young, fit patient, anemia, transfusion dependent, MDS ring sideroblasts, no somatic mutations, trial of growth factors and HMA, no response, still transfusion dependent. Would you consider allogeneic stem cell transplant? I think they're asking basically MDS ring sideroblasts, but no mutation, got ESA, got HMA, still transfusion dependent.
Yes, probably if there is no clinical trial available, is one option. You can try sometimes lenalidomide because sometimes the responses in ring sideroblastic MDS are close to 40 to 50%. And of course, allotransplant is always a possibility when you don't have any available drugs. Even after the disease progresses, but this continuous transfusion also deteriorates the patient status.
Yeah, I think I'll go back to my case. First, make sure that the patient has MDS, because if there is no mutation, check copper levels. Maybe it's all copper deficiency before transplanting somebody. And then, like luspatercept could be an option, but definitely in younger patients. I've had patients with MDS ring sideroblasts that we've gone through several options, and then at the end, we do offer them transplant. Amer will ask you probably to handle this because you've done a lot with the iron chelation. What's your opinion about the Telesto study?
It provided the highest level of evidence we have that chelation is beneficial in patients with lower risk MDS. I guess my big opinion of chelation is that in general, chelation I think is beneficial for MDS patients. The problem in my view is that many of those drugs are very difficult to tolerate in our patient population, which are in their mid-70s, and they have often kidney issues, and they often have heart problems and GI upset and GI bleed and all kinds of things. Hopefully, as we have better options for chelation, I think this is going to be important, because in lower risk MDS patients, many of those patients are going to be treated palliatively. They are not going to transplant. They are in their 70s, and your goal is to prolong their survival, maintain their quality of life, generally by keeping them on sequences of treatments. And I view this somewhat like what you think about of multiple myeloma or changing lower risk MDS into diabetes or hypertension. And one of those things is going to be either you stop transfusions by one of those interventions, or if the patient needs to continue to be transfused, try to prevent the side effects or an accumulation of other things by having better chelation therapies. But I generally would encourage thinking about chelation and trying it. But as I mentioned, many patients end up stopping, unfortunately.
Thank you. Is LAG3 a relevant target for MDS or AML? I'm not aware of LAG3.
Yeah, I mean, it's one of the evolving immune check pathways. It's actually quite well studied in solid tumors, and there is evaluation right now preclinically, and I believe some clinical trials are about to launch both with LAG3 and TIGIT. I guess the big picture is that we know that bone marrow transplant, which is an immune intervention, is the only way to cure MDS patients. DLI, donor lymphocyte infusion, work well in some MDS patients. So immune intervention certainly makes sense. And I think the biggest problem we had with immune checkpoint inhibition so far is that we have not identified the right pathways to target. There are multiple ones, TIM3, maybe LAG3, maybe TIGIT, but also the right setting to do it, which should be, in my opinion, in lower burden disease, in MRD positive settings, and also combination. We have solid tumor studies that combine with chemotherapy or in different settings. So I think my own opinion, something is going to succeed at one point, but we have to figure out how to do it. And having a small number of MDS patients compared to breast cancer or lung cancer or some of the solid tumors is a major problem as well.
Thank you. Is there a requirement for SF3B1 mutation in the COMMANDS trial?
We don't have the data. The patients could have SF3B1 mutation, but we don't have any data of these results for the COMMANDS.
Yeah, we don't have data. The eligibility, it allowed patients RS positive and RS negative, SF3B1 wild and mutant as well. So, Amer, are there any other agents beside magrolimab being examined specifically for TP53 mutant MDS?
there was a lot of excitement with the APR-246, and that in the randomized trial did not pan out. Magrolimab, sabatolimab had some signal in TP53 as well. Immune checkpoint inhibition in general, patients who have TP53 seem to have more microenvironment that is immune suppressant. So immune checkpoint inhibition might in general have a pathway, but I think ultimately you need to have randomized trials. And it's not clear if some of those drugs could potentially work better because there is some direct specific activity because of the TP53, or is it just because those patients do very poorly that it could be easier to show a difference in outcome in a smaller number of patients.
Thank you. TPO agonists in lower risk MDS?
Yes, I think that this is a very good option for patients within the lower risk setting with no excess of blast, and there are several trials performed in this subset of patients, and I think that these drugs are safe and efficacy is confirmed. It's a very good option, but specifically in patients with no excess of blast and in the lower risk setting.
What prophylaxis you use with the Ven-Aza combination when you do it in MDS? Prophylactic for the
I
Aza-Ven.
actually tend to use the same what I use in AML patient, which is triple prophylaxis. So I certainly do antifungal, I do azole generally, and I adjust if I use Vori or Posa, or I adjust the dose of venetoclax accordingly. I use quinolone for antibacterial and acyclovir. As I mentioned, especially early on in the treatment, and we know actually in some of the delay in the initiation of the Verona study was related to the phase 1 study having some infectious deaths, and that was a problem, and the trial has to be redesigned and all of that. So I think it's very important when venetoclax is added, infectious management is a big issue, and we see that in AML. There's actually real-world data in AML that there are a number of deaths that also happen during CR in patients who already responded. So again, I think trying to make sure that you are monitoring patients. I have patients who I keep on antibacterial coverage for 10 months out, or 10, because they have a couple of weeks in which the ANC dips below 0.5. So I think you have to figure out how the neutrophils look like, and you might extend the antibiotic prophylaxis beyond the first 2 or 3 cycles.
Absolutely. Induction before allo, yes or no? If yes, who and what to do? Obviously, that's like a discussion that could go over an hour. I don't think there is a clear answer for that. My bias is I do start treatment before transplant, and probably if we see a response, patients can do better. But it's not confirmed, and you could argue both ways because there is no randomized clinical trials. There is evidence that you can take patients to transplant. Some transplant centers, as long as the blasts are up to 10%, will go directly to transplant. I think it's a very obviously complex question. The prior trials that showed that there was no benefit of chemo, patients got chemo if their blasts were 20%, and the ones that went to transplant directly had like 7 or 8% blasts. So that doesn't answer the question. When you look at patients that received chemo, the ones that were in remission did better. So it's hard to say. And I think at this ASH plenary at this year, we are going to see some data in relapse refractory AML that some patients could go to transplant if they are getting a myeloablative transplant without salvage regimen for AML, which is something like we've never classically thought of. So I think also part of this depends on the transplant and the regimen. Are you using myeloablative or not? In our center, I think maybe it's just a bias, but we try to reduce the blast. We start treatment with hypomethylating agents because it's a definitive treatment. Transplants in general will take 3 to 4 months. Even with the best intent, not every patient is going to transplant. In the P53 population, in our small limited data, we do clearly show if we cleared or reduced the allele burden of the P53 transplanted patients that their outcome is better. Again, I think there is evidence to support both, and there is no right or wrong answer. There is a question also about combining Aza with IDH inhibitors for MDS. Do you give monotherapy or combination HMA IDH inhibitors?
Yeah, so when I use it off-label, I don't combine. I generally tend to use IDH inhibitor as a salvage agent after HMA failure. I have used it on occasion in very old patients who do not want to come for HMA treatment or who don't want to deal with the myelosuppression that comes often with HMA treatment. But I would say, again, it's off-label use. Sometimes you cannot get the drug. Even if you can get it, you have a good discussion with the patient about it. But I personally do not use the combination, even in AML as an audience. No, I think with the agile data showing clear advantage over HMA monotherapy, but many of those patients did not get salvage IDH inhibitor. So I don't know if the best way is to combine it or is it to sequence it. So I think this is an open question, not only in AML, but also clearly in MDS.
Absolutely. How much should we read into a very low level of TP53 mutation of 10%?
In lower risk?
I don't think they specified. We probably could address both lower and higher risk. So a P53 at VAF of like 10%.
Yes, probably it's associated with a higher probability of AML. But I think that it depends on the patient, on the disease evaluation. In Central Left Clinical Trial, we have confirmed several patients with TP53, and we are going to update the results. And even patients with higher rates did not evolve to AML.
I think by the newer classification for the single hit ICC, a 10% cutoff is the cutoff used, but it is significant. There is data showing that if the VAF is higher, like more than 40, they do worse, but still a P53 mutation, you always have to respect that mutation regardless how the VAF percentage.
Maybe I can add to this, Rami. In my practice, I generally tend to hesitate to make decisions based on one time point.
Yeah.
So I think it's always a good idea. I mean, if patient, especially in a patient without excess blast and, transfusion dependence, if someone who's like lower risk otherwise, but is only made like high risk needing transplant by having 10% TP53, I think repeating a bone marrow, repeating assessment in 2-3 months and seeing if that's going up or if the patient is clinically changing. Those tests, I think, are still not fully standardized. I think some degree of clinical judgment should be applied before you just act just based on the number.
Right. Is immunosuppressive therapy in hypoplastic MDS standard of care? Does molecular data impact choice? So I don't think we've talked a lot, but like immunosuppressive therapy is actually an option for lower risk MDS patients. I think the data mostly from the NIH, actually the strongest predictor of response is age. So patients younger than 60 actually benefit from ATG cyclosporin. Some camps prefer to use it just for hypoplastic. I think Amer and I did a meta-analysis in the past showing that hypoplastic does respond. But even patients that have normal cellular bone marrow, if they are young, early in their course of the disease, you could get meaningful, durable trilineage response for 2 or 3 years with ATG cyclosporin. So at our center, if patients are younger, below 60, and sometimes in 60, 70, if they are early in their disease, we may consider ATG cyclosporin, and definitely if they are hypoplastic. Now, we tried to look at predictors of response in terms of molecular information and clinical data. Presence of ring sideroblast, presence of SF3B1, presence of deletion 5q seems to be associated with less response to immunosuppressive therapy. Hypocellular bone marrow, age, as I mentioned. If we had patients that had other mutations, patients that had more than 2 mutations, the duration of response was shorter with the ATG cyclosporin. There are some data older that if patients have like a trisomy 8, if they have small PNH clones, those are patients are more likely to respond to ATG cyclosporin. In the NCCN guidelines, it's listed as an option for younger patients early on. They put that test or like the recommendation for assessing the response to immunosuppressive therapy, and if it's high, you go there. In our center, we use it for younger patients, less than 60 or early in their course of disease. I think this is a question for everybody. For the entire panel, assuming positive data from the Central Rev trial, would you use lenalidomide earlier for lower risk MDS or hold for later line of therapy?
It could be an option. We should try.
I ideally like to see an overall survival kind of advantage. I don't know if the Central Rev is probably not going to provide.
The problem of this trial is that the majority of the patients started treatment after when they become transfusion dependent, and we don't have still a longer follow-up to really confirm the impact on survival.
Yeah, but it's definitely appealing. It's something to think of. I think the beauty of the study is this also transfusion-free survival or time to transfusion dependency. And I think if you think of it as a patient where you're going to go on a treatment for a couple of years only, low dose, and stay 6-7 years not needing blood, if I am a patient, that's appealing, especially even if there is no survival advantage at the end. The other thing is we rarely have active therapies in MDS that can affect the clone. That's why we've not used those treatments earlier. In CML, nobody would agree to wait on, we're using TKI till patient disease is progressing.
Yes.
But our problem is really that we need effective treatments like TKIs in CML. in del(5q), lenalidomide is still not a TKI like CML. You get remissions, you get cytogenetic remissions, but it doesn't eradicate the disease. But I think the data is very appealing that I will discuss it with patients, because going 6-7 years not transfusion dependent is something important, I think, for the patients.
Yes, and of course we have confirmed that with these low doses, the responses are even better. The erythroid responses and cytogenetic responses are even better than when we use this drug in higher dose level. The patients only take 2 years of treatment, and it's amazing that they retain the disease stable with erythroid response. I have a patient for more than 10 years, and it's in cytogenetic response nowadays.
The next question, do we perform bone marrow transplant without bridge to therapy? As I discussed, this is very controversial. Most transplanters will not transplant patients if the myeloblasts are more than 10%. But there are people that argue, yes, you could take MDS patients to transplant directly if you have a transplant ready. Do I do that? No, as I mentioned, I think most of the time we start treatment and try to see if we can achieve a response. But all of that, again, can change based on the therapy we get, based on the type of transplant. There are more and more data coming. Maybe patients that are MRD negative are going to be the ones that benefit from transplant, not the other way. Can TPO be used in higher risk MDS if platelets are very low, along with HMA, any choice? Actually, there was a randomized study, AZA versus AZA L-Trombobag, that actually showed inferior response. So they are like, in a way, antagonistic. So I usually don't combine L-Trombobag with AZA alone. There have been several trials looking at tromiplastin post-HMA. There was signal, but there was some concern about increased risk of leukemia that later was not confirmed. The bottom line, I think, we don't combine them with hypomethylating agents, but if somebody ran off our options, no clinical trial, every now and then we'll try them to see if it will help, but I would not combine them with hypomethylating agents. At least L-Trombobag, there is a randomized trial for that. Thank you very much for listening.
Thank you very much, Dr. Komrokji and Dr. Campelo and Dr. Zeidan, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, an expert discussion on myelodysplastic syndromes, current and future personalized management approaches, and to download the slide sets associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.